Welcome to Recovery Equity, a series of conversations about how we can help and reach more people find freedom from addiction. This is a space for us to reflect on some hard truths and to consider ways forward and even find new possibilities. My name is Demir Ertzen, and I am manager of mental health services at the Hazel and Betty Ford Foundation. I also have an adjunct assistant professor appointment at the Hazel and Graduate School of Addiction Studies. Today, we're discussing the Asian American experience with focus on the intersection of migration, healthcare, and addiction. I'm grateful to have this important discussion with friend and colleague, Dr. Cuong Pham. Dr. Pham is assistant professor in the Division of General Internal Medicine at the University of Minnesota Medical School, also practicing at the Community University Healthcare Center. He has expertise and passion in working with varying cultural experiences, including migrant health and marginalized populations. Welcome, Dr. Pham, and thank you for being here with us today to share your incredible expertise.
Thanks for having me this morning.
To begin, I want to acknowledge that I am not a member of the Southeast Asian community. So that's, I think, important before we get started, because I don't hold all the truths, all the answers, and I don't think any one of us does. That being said, what important considerations, such as cultural factors, are relevant to serving that community?
I think you brought a really good point in terms of talking about our own identities too. And I can say that I'm Vietnamese American, but I'm only one Vietnamese American of, thousands of the community. And of that is a small subsection of the Southeast Asian community, and also a small subsection of the Asian community. And I think that's the complicating part of talking about our identities, particularly our race identities. Important to acknowledge, but also it's not the full picture of the person too. And so, yeah, I will speak about me being a Vietnamese American, being a refugee, coming to the States about a year and a half, not really having any memories of Vietnam, but always having that sense of longing of my culture and wanting to learn more about my culture, being stuck between two cultures overall. And I think that's a lot of people my age, my peers that came from Vietnam as a child, and thinking about Vietnam and the United States in general.
Yeah, that's a really good point you bring up. And how do you leverage that privilege on one hand, as a physician, as a scholar, as an advocate, to lift up voices of marginalized communities while at the same time not imposing your own beliefs?
I think it's that shared connectedness, that narrative, that story that I've had in the past. So when I work with a person that is self-identifying as Southeast Asian or Vietnamese, language helps a lot. I do have like an accent when I speak Vietnamese, has an English accent to it now. But the fact that I can speak Vietnamese to my patients goes a long ways. It builds that sense of connectedness, like, my past, my connection. Language goes with that too. Just knowing the pieces of traditions and things that people do and talking about the conversations of the past, where people come from, all those things help me elevate that sense of connectedness and then trust. And I think that's the thing that we suffer in our work in addiction care or in healthcare, that sense of trust. And then that gap of we cause in terms of inequities and disparities in our care in general.
So how do you bridge that gap of westernized formal medical practice to the cultural beliefs of a group that may not be necessarily grounded in the same thought processes?
Yeah, and I think part of it is we have to learn not to build this hierarchy of what types of medicines are. And I think we want to say evidence-based medicine is the right medicine, but it is full of biases in that medicine. It's built on a structure of many white people, good people, but they have their own experiences in it too. And so when we talk about other structures of traditional medicine, whether that's in Southeast Asia or Asia in general, there are some truths to it. There's reasons why people practice it for thousands of years and why it works overall. I don't think I've spent enough time going through the Western concept of medicine, sitting down and understanding all the Eastern and the traditional sense overall. So I think we need to break that hierarchy and have a sense of like all medicines can be equal, all medicines can be beneficial. And when we come that way, I think it's like, hey, patient, you have these experiences. There are things that you tried that work for you. Let's give that a go. It's not been harmful for you. here are things that I've learned in my practice that might be beneficial for you. Let's make things complement things better overall.
And that makes me think of two things. One, the first being that a lot of migrants, and especially those from the Southeast Asian community, have a lot of deference towards medical providers. So there's always that potential of unintentionally acting in a way that is, I don't know if harmful is the right word, but that isn't helpful. And the second thing is, there are instances where people flee persecution by medical providers who may also represent institutions like the government that have facilitated that. What are your thoughts around, practicing within a very confined space while having all these different factors
Yeah,
in the
yeah,
room?
yeah. So I think that's a little bit like the old school way of medicine in the Western approach is very paternalistic versus very shared decision making place. And I think they both are important in different ways. It depends on the encounter with that person, maybe the family members around them too, when you're having these conversations. There are times where I can tell that the individual will defer to me no matter what I say.
Mm-hmm.
It doesn't mean that I can't take the opportunity to educate and then inform them. And it might be not just informing that person, it might be that family member around them too. And I think often when Asians or Southeast Asians comes into my clinic, they don't come by themselves.
Right.
They want to make a decision with their family too, or if they have an elder, they will lean on that elder for advice. Or if they have a elder leader in the community, they might lean on that person for advice. So I think informing as much as you can, even if that first time they want to just defer to you because they're reluctant to make that decision, that conversation just can't happen sometimes in 10 to 15 minutes. It might be a series of conversations when they feel more ready to say, I'm ready to make some of these decisions with you rather than just wait on you to make that decision by yourself.
And that makes me think of when I was growing up, I would interpret a lot for my parents and translate regardless of whether or not there's an interpreter. And part of that I think was the trust and the belief, because if that's been violated historically in the past, you're very hesitant to engage with others. So how do you navigate that in a setting that's westernized, for lack of a better words, where there may be policies and protocols to engage interpreters that are hired and not the family members or community members in the room?
Yeah, I think in an ideal world, we wouldn't need interpreters, right? We'd be able to communicate in this natural way without worrying about that sense of I'm going to say something that you don't understand, or the patient's going to say something that I don't understand. But our world is full of diversity, and we have fun languages, different ways of communicating, whether it is just how we speak, but
Mhm.
also the way we use our hands, our facial impressions. So when we throw like another individual into the room, it's always going to be more complicated, right? Because and then for you as a child to be an interpreter, that's not fair for you because you're trying to understand something that is a higher level than you.
Mhm.
You probably didn't have the skill sets of interpreting in the
Right.
first place and how to actually convey what your parents are saying to the provider. And so in the secondary ideal situation is we have trained interpreters for all these encounters. And I think the hardest part actually is not always having the right interpreter, but the family being okay to have an interpreter too. Because again, it comes to the sense of connectedness and trust. Is like I've never needed a person in between me and my doctor before, and suddenly I have to have a third person sit there and listen to the very vulnerable details of my life. Can I trust this person? This person might be even in my community too,
Mhm.
and we might be talking about things that are stigmatizing in the first place, and they don't want those things to be shared within the community. So building interpreters, working with interpreters, building trust with interpreters, and having those interpreters also work with the community. This all comes together where there is more connectedness overall, but that takes time and practice too. So in this past year with the pandemic, I've had a lot more online interpreters, people I've never worked with. It makes it so much harder than the ones that I work with in the office. Because I know them. I know what they do on a daily basis, how they interpret it, how they interact with me, how they interact with patients, their weaknesses and their strengths, and they know my weaknesses and strengths too. And then those conversations are way easier to navigate than someone I don't know online.
So speaking to the openness and having those discussions very much like we're having now with the communities we serve.
Yeah.
We're at the point of um, sharing very sensitive experiences, which unfortunately refugees by law have to have gone through some traumatic events to gain asylum in the United States or elsewhere. How does that experience impact not only access to care, but also treating comorbid mental illness and maybe addiction?
Yeah, I think, when I started first doing addiction care about 4 years ago in my clinic, my attitude was to ask every question I needed to know, like literally shotgun the questions, like a checklist of questions overall. But what I was doing was I was actually traumatizing my patients too. I wasn't thinking how the room was ready, how the patient was ready for some of these questions. So for me, what I've learned is when is it time to talk about the trauma? Does it need to be now? Does it inform me of the decisions that happen in this very moment in the next 10, 15, 20 minutes overall? My purpose is to connect with individuals and understand their story and what their goals are. If that story of that trauma is important to know, I will get to it at some point. And when they trust me and when I build that connectedness with them, I will hear about that trauma at some point. And it might not be in the typical ways that I would ask is, did you have sexual abuse? Did you have
Mhm.
violence? It's not those direct terms, but they might be giving you clues of what their experiences are, where you can start connecting the dots after several sessions, you know, of building that relationship with those individuals.
You mentioned too shifting from general internal medicine to practicing addiction medicine as well. And it's interesting to me that I've done asylum evaluations, I've testified in court, and it's very common to talk about mental health, well being as a result of trauma. Addiction happens, it's prevalent. I think it's more stigmatized than mental health. And despite that knowledge and the foundational understanding we have, it's left unaddressed oftentimes. Can you say more about that and how you've integrated that into the way you serve the community?
Yeah, I think it's practice. I didn't have the language before, right? Medical school doesn't give you that language. Residency doesn't give you that language. I always convey the ideas of like, they gave me the tools of asking someone's sexual history. And the first time I did it was really hard and complicated and awkward.
Mhm.
But you got to practice it. And if I don't practice the tools of learning about a person's story about their depression or their story about anxiety or trauma or the story of their drug use of why they end up using heroin or fentanyl, I have to practice that in a way that I can ask those questions where they feel comfortable to tell me that story back, not feeling judged at that very moment too, but just listening to them. So I have to practice the way I say those words and how I receive their words at the same time.
Dealing with our own discomfort with addressing those things, would you say that an effective approach in the beginning might be to be transparent?
Yeah, yeah. From my first encounters with patient, I tell them how my philosophy of work is, and often I do talk about shared decision making and making decisions together. I make recommendations, but I don't control their decisions at all. And I think that transparency from the very beginning is important too. I do talk about sometimes things like child protective services, policing, the judicial system, and being very like, these are systems that will maybe work with us. And sometimes there's a systems that work against us overall.
Mhm.
So we got to talk about everything that's in the books here in the systems overall when we talk to patients. And I think accepting those boundaries, those truths are important for them to understand.
Right? Maybe being bound by an ethos of laws, rules, regulations, while also navigating a way to build relationships and trust with a community that's experienced a lot of the opposite, I guess, if you will.
Yeah. I think people rather know the truth,
Right.
rather than learn the punishment later, or wherever that is later to them.
So what do you think about the way stigma and a relatively punitive immigration system, at least historically, have perpetuated that trauma?
Yeah, that's
Another
tough
big
because
question.
there's so many barriers that people experience, right? Getting to become, and I think a lot of refugees and immigrants want to become Americans, right? On their own choices too. But there's that sense of I think us who have been integrated in the system, we block that. We have a sense of fear of who those people are and why they came here, because they're going to take our resources. Rather than we elevate each other, we have this sense of the unknown that causes so much fear about what those individuals are doing. So I think that's built into the system right away. And so our system is just built in fear than it being welcoming.
All that being said, what are some parting thoughts that you have for providers or community members serving such populations?
I would say it's working with refugees and immigrants is just pure fun and joy. I relate it like learning new things on a daily basis, sharing new conversations, learning bits and pieces of the world that you've never seen and heard before, and having an adventure outside of your own home and state on an ongoing basis every day. So I would welcome anyone to want to work with the population I work with, because it's just pure joy.
Well, thank you, Dr. Pham, for joining us today. On behalf of everyone watching or listening, I want to express my gratitude for taking the time again to speak with us today. You've given us a lot to think about in terms of our practice and advocacy efforts. And to everyone out there, please let your friends and colleagues know about these conversations and come back often for more episodes of Recovery Equity. Together, we can build a healthier, happier, and more equitable tomorrow.